Much for attending this webinar on rehabilitation equipment. I'm going to make some housekeeping announcements. Once again, at the bottom of the screen, there is a chat box where you can write your names, the name of your country and institution, and also there is a Q&A tab where you can ask questions for the experts panel that we will be discussing with later. And you can also choose the ellipsis circle to choose the language of your preference. There will be a simultaneous English and Spanish interpretation available. There is also representatives from Caribbean countries, from Turks and Caicos, from Ecuador, El Salvador, and also from other regions. We have a participant from India. Great. The age of information and technology reaches everywhere. St. Lucia in Mexico. Now we're going to, without further ado, I'm going to turn it over to the head of our unit here, Silvana, for the opening works. Good morning. Thanks very much, Gustavo. It is a pleasure to have you all here with in this rehabilitation equipment webinar. Taking advantage of the fact that we have participants from all over the world and the Americas and the Caribbean, I'm going to switch to English.
Today, we're going to focus on rehabilitation equipment in the first level of care. And it's a real pleasure to welcome all of you. We have more than almost 250 people connected from across the Americas region, but across the world as well. And I especially want to say a special welcome to our colleagues from Ontario Tech University and Emory University that are WHO collaborating centers with us in rehabilitation, as well as our colleagues from the PAHO member states who are going to be talking about their experiences with us today, and the World Federation of Occupational Therapy. And we're really thrilled to bring to you this excellent program to discuss the need and importance of integrating rehabilitation services into primary health care. And we're also pleased to launch a new fact sheet where we're going to highlight the list of essential technologies, rehabilitation equipment that is appropriate for the first level of care, as a practical resource to respond to the urgent and growing need that we know exists in our region. We see that rehabilitation has become and is a very essential part of health system strengthening, especially at first level of care where people receive most of their care and services. And needs are increasing because of population aging, as well as the rise and burden of non-communicable diseases, mental health injuries, and increasing in functional limitations. So today in the webinar, we're going to highlight that rehabilitation should be integrated and can be integrated into primary care with the benefits of improving access, reducing pressure on specialized services, supporting individual recovery, and promoting independence and community participation. And we're also going to launch this new fact sheet to make an important case that rehabilitation is not just for specialized settings, but it can be delivered in primary care. And we're going to present the practical and affordable set of rehabilitation equipment and assistive devices that are appropriate for primary care so that we can help support the many professionals that we know across the region that are providing essential rehabilitation services to assess functioning, to provide care to people with musculoskeletal, neurological, cardiopulmonary, neurodevelopmental, and mental health conditions. So we will demonstrate also through these case examples that rehabilitation at first level of care is feasible and affordable when the right equipment and the assistive products are available. So again, thank you to everybody for joining us today, and a special grateful to our colleagues and collaborating centers for their commitment to advancing rehabilitation in the Americas. Our partnership together really reflects the shared understanding that expanding rehabilitation services, including expanding access to rehabilitation equipment, is central to universal health coverage. We hope you learned something new from today's webinar, and we hope that it motivates you to go back to your rehab services and expand access to rehabilitation equipment. Thank you again, and wishing you a great webinar. Back to you, Gustavo.
Thank you very much, Silvana, for your outstanding opening remarks. Vamos ahora a compartir con vosotros una breve presentación sobre la importancia de este
Now we're
documento
going
como
to share
junto con la
with you
serie
a
de
brief
trabajo de nuestros dos centros
presentation
colaboradores, la Universidad
that we
Tecnológica de
have
Ontario en Canadá
prepared with
y
the
Emory en Atlanta.
Ontario
Voy a
Tech
pasar ya
University and the
rápidamente
Emory
a
University
ellas.
in Atlanta. On this issue, I'm going to share my screen with you right now.
¿Me dejan saber si ven mi pantalla?
Let me know if you can see the
Sí,
Bueno,
adelante.
estupendo.
screen.
Muy bien, pues
Yes.
me gustaría empezar
So I would
compartiendo con
like to start
vosotros
by sharing with
esta
you
idea
that
de hacer una publicación al
this
respecto
idea of preparing this
de
publication
rehabilitación.
about the
Nació precisamente de una publicación
rehabilitation equipment was
hace
born
unos
from a
meses
communication
sobre el
we
valor
shared
añadido de la
a few
rehabilitación.
months ago about
Esta
the
publicación está
added
disponible
value of
en el
rehabilitation.
PAHO de 2025, tanto en
This
español
is
como
a
en inglés.
communication that's been
Y la
available in both
publicación
English and
entonces
Spanish since
enunciada
mid
cuatro puntos
2025,
importantes que me
and
gustaría
it
destacar
makes
con
clear
vosotros.
four
El
highlights that I
primero
would
es
like to
atención
underscore, share with
primaria y
you.
primera de
In the
salud.
first place, first
Se
care,
identifica sobre todo
first level
la
care,
funcionalidad, es decir,
it
todas
basically
las
focuses on
entidades federativas
functionalities. That's
tienen
when we
disfuncionalidad y
really
algunas delimitaciones de
realize
intervención primaria y
that
de segunda.
functional
Por lo tanto,
limitations
es la
are
puerta de entrada
identifiable. So it's the
inicial servicio de
gateway to a
rehabilitación.
potential
También es
rehabilitation
importante
service. It also
destacar que todos los servicios de
must be
atención primaria
recognized that all
son muy cercanos
first
o
level
muy
care are
compatibles
very
de la mano.
close as
Suelen ir a
possible
servicios
to
de
the
rehabilitación que suelen ir a lo mejor en
places
zona
where
rural
the
o más
people live
alejadas
in rural
de
areas
niveles
or
de servicios
perhaps
tercer nivel.
where they're further
También,
away
por
from
supuesto,
second and
salió
third
una
level
cosa que también es muy
hospitals.
interesante y es que
Another important
hay
conclusion in those
pacientes
documents is that in these
incluso más del
medium and low
50% de
income
la población que
income,
necesitan rehabilitación
over
no tienen acceso. Por
35% of
eso
the
es
people
la idea de la importancia
who
de
need
introducir
rehabilitation like access. And
la
that's why it is
rehabilitación
so
en los
important to
primeros niveles.
introduce rehabilitation
Y
in
por
the
último, la
first level of
conclusión más
care.
importante de
And
todas
I think the last and perhaps the most important
es esa
conclusion is
implementar
that
servicios de
oftentimes to
rehabilitación
expand a
precoz,
rehabilitation
donde no
service at
hace
the first
falta
level of care,
equipamiento de alto
we
coste.
do not need high cost
¿Por qué
equipment.
la
And
rehabilitación es importante?
why
Porque se
is
realmente
rehabilitation
un
important?
sistema de
Because a
rehabilitación
system, a rehabilitation
puede
system,
llevar a un aumento de
can
cobertura de manejo de
increase
enfermedades no transmisibles y también transmisibles, ¿no? Entre
lack of
comillas,
this service
transmisibles
can
como
increase
por
the
ejemplo las
cost
enfermedades
of
cardiovasculares. Pero también estoy pensando, por ejemplo, en
care
trastornos
in many
cardiovasculares
areas like
inflamatorios. Sabemos que el
cerebrovascular,
porcentaje
respiratory
de
diseases and
discapacidad
conditions.
también
We
puede
know that the
tener
percentage of
impacto
disability
cuando
can also
las líneas de
increase
atención no están
when
apropiadas.
rehabilitation needs are
Porque
not
la
met,
rehabilitación
because
y la intervención
rehabilitation and
no son
functionality and
prácticamente
functioning
asociadas.
are all
Por lo tanto,
intimately
la
related,
rehabilitación
and therefore
puede aconsejar,
rehabilitation
puede
makes a
participar no
community
solamente
to
de la vida
uh,
laboral, sino también de la vida
become
comunitaria.
involved not
Todos
only in
sabemos que un sistema de rehabilitación
labor
bien
life but also in community life,
administrada
and
genera
it
un
is also
aumento en las
a
hospitalizaciones,
door of
así como
entry
un aumento en los gastos del gasto sanitario
to
global del
reduce
país.
global
Y por último,
healthcare
existe
expenses for a
también
country.
una
And
relevancia directa, una relación
there
directa
is
entre la
also direct
rehabilitación y
relevance
resultados
between
en salud
rehabilitation
y
and
previene
health
cualquier
outcomes
intervención.
after an intervention.
Cualquier intervención en
I am
salud,
thinking about
ya
any
sea
kind of health
relacionada
intervention
con
where
enfermedades
rehabilitation
cardiovasculares,
can become a part of
cerebrales y demás.
neurological,
¿Cuáles son los beneficios de integrar la
cardiovascular, etc. What are the
rehabilitación
benefits
en
of
los primeros niveles?
integrating
Bueno, pues también están demostrados, ¿no? El primero es que
rehabilitation in the
la
first
mayoría
level of
de
care?
intervenciones de
That's also been
rehabilitación
demonstrated.
estándar
Most
se pueden llevar a
rehabilitation
cabo en el
interventions
primer
can
nivel,
also
es decir,
take
no
place at the first level of
necesitamos
care.
estructuras
We do
más
not need
específicas y
structures and
avanzadas
equipment
que nos
that are
ayuden a
super
mejorar la
advanced that will
funcionalidad
allow
del
to
paciente.
improve people's
El segundo, pues
functionalities.
que nos
A
ayudaría
second
a reducir los
issue
gastos
is that it'll
médicos
help
porque
it to
una
reduce
población más
health costs
saludable
because
y con
a
alta
healthier population with a
puede
high
requerir en un
level
futuro
of
menos
function and
gastos
may require in future
y por
less health
último,
expenses.
este
And
acceso
finally,
va
because
a
this
mejorar sobre
access
todo la
will
evaluación y atención
improve
para
as a
aquella
whole
población más
the
vulnerable, ¿no? Aquella población que no tiene acceso a los
reduce
servicios más
the
especializados.
vulnerable
Y ahí
population
ya
who
mencioné
do
cuál
not
es
have
el siguiente
access to more
paso y es el
specialized
siguiente
services.
producto, ¿no? El que hemos
As a
presentado
result of this
junto
one, we
con nuestros dos centros
prepared the
colaboradores, ¿no? Los
second
centros de
products that we
Ontario,
have
Canadá
prepared with
y
the
ahora Emory.
Ontario Tech University and Emory
También en
University.
nuestra página web
That is
están
also available
disponibles.
on our page both in
Con
English
este
and Spanish.
documento hemos querido
And
resaltar
in this
la
document, we have
importancia
underscored the
de este
importance
documento
of
sencillo, pero a la vez
simple
enormemente práctico
but
para llevar a
very practical equipment for rehabilitation services. This document aims basically at advocating not only the technical side, of course, that is also important. That's why we have the experts that will be joining us later today, but also it's a call for action and integration of a rehabilitation to the first level of care, because from the cost effectiveness viewpoint, that has been proven. And this means that perfectly accessible rehabilitation services have a very high impact on care, healthcare. And based on a very recent evidence that has been published by the World Health Organization, that's the rehabilitation intervention package that shows a number of interventions and rehabilitation in a number of areas, all the way from skeletal muscular, neurological, cardiorespiratory, neurological development, other communicable diseases, and else. And for this document, we have a focus on those pathologies or interventions that we feel are more frequent at the first level of care and which have a greater impact. They basically address mobility, that's the musculoskeletal, cardiorespiratory, those that are related to neurodevelopment and mental health. And finally, underscore the importance that most of these products are accessible, affordable, easy to maintain, and therefore easy to access in low and medium income countries. I think this is the key of this document that we would underscore. And when you look at the document, you will see the list of equipment and devices that we think can help us address these conditions that we just mentioned, and that are not exclusive to these five conditions. We can go much further to include mats, weights, oximeters, supports, etc. And also, when it comes to support technology, that is the products that will allow us to get better rehabilitation outcomes, like, for instance, canes, walkers, memory and communication aids. That's a number of tools that'll allow us to carry out these rehabilitation and support technologies. What will this equipment allow us to do? On the one side, to have a basic equipment to evaluate functions. That is basically the focus of our intervention, to evaluate the functionality of a person, and on the other side, to carry out easy and simple interventions that'll have a great impact on the people's involvement. And finally, to provide a proper follow-up of staff needs. We're aware that in the Americas, we do not have a large staff or human resources for rehabilitation. For this, we have another set of tools that are also available to countries. That's the basic package of interventions, for rehabilitation services. That is another one of the tools that we have. What are the key messages? In the first place, we do not mean to go beyond the first level of care or community level. That's and for the health conditions that the five ones that we just mentioned, conditions, and as I insisted, there is a clear impact on planning and advisory. So the financing at the first level of care, this is not complex or complicated. This tool has a very strong component of science evidence that's based on the World Health Organization's intervention package, and also for the integration of rehabilitation to the first level of care. The document shows a the intervention packages, the technology, staffing, web portals, rehabilitation routes, rehabilitation needs globally are all shown there. So this is the end of the introductory presentation of the meaning of the intervention at the first level of care. And now I would like to turn over to what's the most important, interesting part of the webinar. I'm now going to invite all the panelists to open their cameras, and I'm going to introduce the panelists that are. We have Dr. Federica Montero, Assistant Director and Director of the Social Security, Costa Rican Social Security, and Consuelo Zamora. She is a occupational therapist and member of the World Federation of Occupational Therapists and director of the Ensemble IT. Also, Maria Lisa Alvarado from the Salvadoran Rehabilitation Institute in El Salvador and head of the Strategic Health Policies at the Salvadoran Social Security. Also with us is Marcela Guzman, who is the head of the Rehabilitation Service at the Pedro Glacer in Santiago de Chile, and of course, Yasmin Garcia, who is the consultant at PAHO, and of course the participants from our two collaborating centers, Melissa Alton Graham from the Ontario Technological Institute in Sarah Pollen, who is director of the Emory University in Atlanta Collaboration Center. Thanks to all of you for making possible this document and providing the technical document to prepare and make available this document to all of you. And now we're going to continue with the questions and answers. The first question is about the importance of rehabilitation in primary health care. Then you will have each of the participants will have a couple of minutes for you. The first question is for Marcela Guzman. From your viewpoint, why is it important to integrate rehabilitation in primary healthcare in medium and low income countries in the Americas and the Caribbean, and what would be the impact of such an incorporation? Good morning, everybody, to all those who are connected, and thanks very much for the invitation. I will only have a couple of minutes. I'm going to start by addressing these questions right away. In the first place, I think integration rehabilitation to a primary health care is critically urgent and important and necessary, in particular in the lower resource countries. In my viewpoint, a historical mistake in health is to create stages in healthcare. And in these stages, rehabilitation was always like in the final care stage, in that focused care in hospitalization stages, and rather than an inclusive development with a focus on people's rights. And WHO and PAHO has determined that rehabilitation is not optional, not exclusively for serious disabilities. Countries have a little development generally on rehabilitation. That is, rehabilitation focus in hospitals is inefficient and insufficient and is distant from people, and this increases the time and opportunity for care, which has irreversible consequences, and increases also the delay in reincorporation into daily lives. I think, however, that rehabilitation is not an expense, it's an investment, and it's highly profitable. The investment that is required is not very high, but the accomplishments and the outcomes by reincorporation into the labor life and greater functionality are immeasurable. In regards of the integration of rehabilitation into primary health care reduces the expense and the delays and the social expenses and has a benefit on the most vulnerable populations access by lowering demographic barriers improves the rehabilitation of persons that have chronic health conditions or reduced mobility in creating these services and the first level also reduces the fragmentation in improving access to comprehensive healthcare networks that focuses on people and not on the institutions. It improves the relationship between the various levels and it allows to coordinate actions and prevent duplication of services and principally reduces abandonment of persons by making rehabilitation closer to their places of residence, and it also improves the governance and the possibility for states to create policies that can take care of the scarce resources and by providing continuity in care and a policy to keep these strategies in place will take better care of a physical and human, qualified human resources. Thank you very much, Marcela. Now we're going to have the same question to Dr. Gallardo. Yes. Good morning and thanks for the invitation, Gustavo. In the first place, I wanted to mention that as we are all aware, 1 out of every 3 persons worldwide require rehabilitation. Historically, we are all aware that rehabilitation has been understood as specialized clinical service. That has been the perception that we have had historically, and that it should be provided basically in the secondary and tertiary levels of care. So it is important to include rehabilitation services in the first level of care that are low cost and are cost effective and sustainable to create effective results for low complexity conditions. It is important to incorporate rehabilitation at the first level of care, which allows not only early interventions but also to preserve functionalities and prevent further complications. To assure this early access to rehabilitation services allows to accomplish optimum results in other medical interventions and prevents complications along the course of life to preserve the quality of life and reduce the cost for the entire health service in El Salvador. We have shown interest in implementing the 2030 rehabilitation strategy for 2030, and we are now in the second stage of the national rehabilitation service. So we use the maturity rehabilitation material level that made possible to realize what was common with other Latin American realities and a recommendation to reinforce rehabilitation services in the first level of care. We believe that through resilience in this health public health issue can reintegrate and keep their citizens in their own territories by diminishing disabilities in the longer term. Now, let's ask Federico Montero the same question.
Está muteado el micrófono. A ver.
Your microphone is muted.
Si lo podemos encender. Ahora sí.
Disculpas. Muchas gracias, Gustavo, por la invitación.
Thank you very much, Gustavo, for the invitation. Greetings to everybody, to the panelists and all the participants across the region and outside the region that are participating in this activity. I would like, or I will
un aspecto importante es
including the
esa gran brecha
answers
social que
that
caracteriza
we
a América Latina y
take account of
también
this
las
large
diferencias tan
social
grandes que
gap that is so
existen
characteristic in Latin America and the great
en
differences
nuestros
or
sistemas de salud.
significant differences in our health
Costa Rica
systems.
tiene
Costa
ciertas
Rica has
características, como
certain
todos los demás países,
characteristics, and
tiene sus
we
propias
are aware
peculiaridades.
that
Y
all
no en
countries
todos
have
los
their own
países
peculiarities, and not in all
el
countries
nivel
do we
tiene
have
un segundo nivel o un tercer
a
nivel
second or third
suficientemente fuerte y
level
establecidos para poder
of care that is
apoyar,
sufficiently strong
asesorar y apoyar
to work and
estos grupos.
support
Sin
the
embargo,
first level of care.
en el
However,
documento de OPS,
I think that the
dos
PAHO
aspectos importantes se
document
mencionan, que son los aspectos
includes two very important
sociodemográficos,
issues. That's
que son
the
muy relevantes
demographics
para
that
el
are
análisis
relevant
de la
for
importancia de la rehabilitación en
the
cualquier nivel de atención.
underscore the
Y
importance of
dos, no solamente el
integrating
aumento de las chronic
rehabilitation in the
conditions, sino que
first
también
level of care, not only the increase in the chronic conditions, but also
ambos
the increase in the
procesos
people's life
íntimamente ligados.
expectancy. Those are two
Ambos aspectos que
interrelated
determinan
aspects that
la
to a
funcionalidad de
large
las
extent determine
personas.
the functionalities of
Entonces,
people,
el poder
and
tener
therefore
recursos
to have
que,
resources that
que de alguna manera modifiquen la
somehow
funcionalidad de las personas
modify
en sus
people's
comunidades
functionalities in their own
en
communities
relación
at the first level of
con
care
recursos técnicos
with
básicos, elementales,
basic
ya
elementary technical
mencionados,
resources. As
no se
Gustavo
necesitan
said in his presentation, we do
grandes
not need
infraestructuras para poder proporcionar atención
significant
en niveles
technical resources to
son
provide
muy básicas
care at the
y
first level. We need very
definitivamente
basic things,
a
but
influir
definitely that'll have a
en
great influence
el
on
potencial funcional de las
the
personas y al mismo
people's
tiempo contribuye
functionality
a
potential at the
ayudar a las
same time it
comunidades
contributes
a
to
tomar
help
conciencia
communities to become
de
aware
la discapacidad.
of disabilities issues.
Es importante no
It is
solamente
important
tener
that we not
reconocimiento,
only
sino que
both things
las
are
alianzas
important, but also the
no van a ser
partnerships. And I think
solamente
that
con
we have
centros
been
especializados
working
en geriatría.
away from specialized services like
Juega un
geriatrics. I
papel muy
think that
importante y
geriatrics
especialmente
plays a very important role
el área de salud con el cual
in
estamos
health
muy estrechamente
services that we should
relacionados,
be
dada
working very closely with to
la
take into
edad
account
y el aumento de las
age and
expectativas
the
de vida y las condiciones
longer
crónicas que afectan a muchas
life
personas
expectancies and many
a este nivel.
chronic conditions that we
Bueno, pues muchísimas
work
gracias,
with at this level.
Montero. Muchísimas
Yes.
gracias a los tres por esa
Thank you,
primera respuesta que yo creo
Dr.
que
Montero, and thanks
encaja
to the
perfectamente
responses in this first round that
sobre el
fit
valor de la
perfectly in the
rehabilitación a
initial
nivel de
issue
enfoque
about the
europeo y
value of
sobre todo
rehabilitation in the
viendo en este
first
momento
level
para países de
and
mediano y bajo ingreso, pero
for
también, ¿por qué no?,
low and
para
medium
países
income
de alto
levels,
y
but
de alto
also
ingreso,
for
porque recordemos que la
medium and
rehabilitación,
high countries,
muchos
because
países de mediano o alto ingreso
rehabilitation, even
muchas
in the
veces
medium and
no hay rehabilitación en el
high
primer
income
nivel.
countries, does not
So
reach
here
everyone or
we
is not
have to
available
go to the
at this level.
collaborating
So
from the collaborating centers. So from your perspectives, how does the rehabilitation equipment fact sheet support the rehabilitation for undeserved population in middle and high income countries? So Dr. Sara Pullen, over to you, please. Thank you. You're muted, Sarah. That's okay.
Sorry.
Thank you. That's okay. No worries.
Thank you, Gustavo, for this question, and bienvenidos a todos y todas. Underserved populations in middle and high income countries are really often overlooked as they can get lost in a busy urban environment. So, due to crowds or people sleeping under bridges, sort of these people who are really lost in our society, and as well as rural, more remote areas because of the remoteness, because of living sort of far from the eyes of public health and low accessibility, they can also overlook. In these areas, and I'm speaking from the US perspective, given right these areas.
Sorry, Sarah, you're frozen. Maybe you can turn off your camera.
Oh, sure.
Thank you.
Okay, is that better? Yeah, okay. So in these areas of the US, NCDs such as diabetes, hypertension, other chronic conditions are highly prevalent in both of these settings, but both prevention and treatment are really lacking in these areas, again, because of the hiddenness. This is a population who really stays hidden, again, because they are sleeping under bridges or in doorways and or in shelters. So in these settings, both prevention and treatment are lacking. And this leads to high prevalence of things like strokes, other neurological events, or cardiovascular events that require rehabilitation. And in addition to these, let's say, events, this is people who really require rehabilitation. And not just these events, but because these populations are also experiencing just the natural effects of aging. So, such as arthritis or chronic disease, again, hypertension. And in the fact sheet, we're really reminded that globally, the current need for rehabilitation greatly exceeds the availability of services, and that most rehabilitation interventions can be delivered at the first level of care. And that's one thing I believe the fact sheet can really be helpful in a global sense, that not only is there a low need for it, but that it can really be delivered in the first level of care. Primary first level care service, such as mobile clinics, I know in the US, for our unhoused homeless populations, will have mobile medical vans that will go out into these areas. Again, they'll stop under bridges, or they'll stop at night on the streets, and also clinics, so free clinics for people who are underserved. And that's mostly what's available to underserved areas.
Mhm.
So again, being able to include this equipment on things like, mobile vans or clinics for people who are unhoused or homeless is really an excellent idea. And the rehabilitation equipment and assistive products listed in the fact sheet can be an excellent resource, demonstrating that rehabilitation services can be delivered effectively at this first level of care with really simple, low-cost items that could be life-changing or life-saving for these populations. I see a lot of people, even just where my clinic is in a really urban, underserved area. I see people with diabetic amputations who don't have a wheelchair. I see people who've obviously had a stroke. And if you think about some of this essential equipment, it does not take up a lot of space. So if you think of canes or even folding walkers, this does not take up a lot of space and could be stored on things like vans and mobile clinics.
Thank you. Thank you very much. Same question for you, Alisa. Over to you. Thank you.
Thank you, Gustavo, and what a pleasure to be part of this panel. So with respect to the fact sheet, from my perspective, this offers a very important starting point for improving access to rehabilitation services in underserviced areas where there are no rehabilitation providers, especially in Canada. So in Canada, there are many rural, remote, and northern communities that are geographically isolated from rehabilitation services. So people in these communities, many of which are Indigenous communities, have to drive hours, or in some cases, take a flight to see a rehabilitation provider for an assessment or for treatment, and sometimes for something just like back pain. So this is really significant when we consider that in a high-income country like Canada, about 30 to 40% of the daily cases seen at the first level of care are musculoskeletal conditions that could benefit from rehabilitation. And yet, there are many populations who are cut off from these services because of travel and cost constraints. So the fact sheet really has this potential to benefit these communities by posing a pathway forward for addressing equity issues related to service gaps. It demonstrates that very few resources are needed to ensure that people can receive rehabilitation support in a timely fashion and at home. And this was emphasized by the other panelists. And so I think this tool can really help policymakers, even in high-income countries, and healthcare providers as well, understand the value of equipping the first level of care as a way to start improving healthcare services and the lives of people in underserved communities. Thank you.
Thank you very much. Muchas gracias. Vemos realmente como también en países de medio y alto ingreso también hay necesidades en rehabilitación.
Thank you very much. We see there are also rehabilitation needs in high-income countries, and they can be tackled with low-cost equipment. The next question goes to all panelists. Please, let's talk just for 2 minutes so everybody has the time to speak. Question number 2 is related to the care model and the organization of rehab services, because we cannot have a publication on equipment without taking into account services that go hand in hand with it. So the question is, what are the strategies that are more effective for integrating rehabilitation to primary health care in an institutional facility or in remote areas with just a few resources? Consuelo, you have the floor. Thank you very much, Gustavo. Thank you very much for this invitation. Good morning, everybody. First of all, I'd like to give you some context about rehabilitation in Haiti. These challenges are realities that occur in other countries in the region too. Rehabilitation in Haiti is quite recent. It started mainly after the 2010 earthquake. To date, it hasn't been fully integrated in the public healthcare service. So services depend on private organizations or on NGOs. Also, the occupational therapy and physiotherapy careers in the country just started in 2016. Later, the country faced an important migration of healthcare professionals between 2020 and 2022. As a result, access to rehab services is very limited for most of the people, particularly in rural areas or areas that are difficult to access. Also, access to support technologies and knowledge about the benefits of rehabilitation. In this context, the most impactful strategy has been to approach rehabilitation to people and communities in a country where, to a great extent, they live away from available services. So waiting for people to come, it doesn't work. So we develop mobile clinics, satellite clinics that are integrated. We always try to start from primary health care establishments, and other strategies for functional assessments, follow-up, is support technologies closer to people. This reduces geographic, economic, and social barriers and allows to start rehabilitation processes at an earlier stage. The second strategy has been to strengthen capacities of healthcare workers, nurses, orthopedists, and all of them, so they can acknowledge functional limitations at an early stage, understand the importance of rehabilitation, and activate referral mechanisms when necessary. It's also been fundamental to strengthen coordination about all these healthcare service levels. Sometimes there aren't services, but when there are services, it's important for the patients to go along different care levels in a coordinated and timely way. Also, integrating rehabilitation at the first level does not imply having very highly specialized services in each community. It implies that you guarantee that anyone who has a functional limitation will have early access to early assessment, initial guidance, support technologies, and clear referral mechanisms, because as we know, rehabilitation is much more effective when you start at an early stage, and approaching it to the first level of care allows us to prevent more complex disabilities, complications, reduce access barriers, and significantly improve functional results and participation of people in their daily lives and communities. Thank you very much, Consuelo. Very clear and key messages. It's really working with this multidisciplinary approach. 2 minutes, please, I insist. Marcela Guzman now. 2 minutes.
Tenemos por ahí a Marcela.
Marcela?
Ahora sí.
Ahí sí. Bueno, en cuanto
Well,
a las estrategias que se han utilizado que
concerning
han
the
sido
strategies we
positivas, creo que
use
también hay que darle un
that
poco
have been
contexto en cuanto
positive, I think we have to give some
a
context
los tiempos, ¿no? A los tiempos
concerning
de
times.
vida de cada uno de los países. Aquí en Chile, principalmente acá
And
en principios de
also
los años
the
2000,
living
se
conditions in
implementó
each country. In
la
Chile,
RBC, ¿no
in
es cierto?
the
Como
two,
estrategia
at the beginning of the
exitosa aplicada en
2000s, we
desarrollo.
started
El Instituto en particular
RBC
formó
successfully. The
importante en el desarrollo de
idea
esta
came from
estrategia que pretende
Japan,
acercar la
and our
rehabilitación a las
institute
comunidades con
approached
un enfoque
rehabilitation to
psicosocial y
communities
capacitar a los
with a
equipos locales.
psychosocial
Sin
approach,
embargo, con el paso del tiempo,
and
la RBC
also
se ha
training
convertido de alguna manera en
local
prestaciones de salud, más
teams.
y
But
en muchos
this is
lugares,
more and
digamos, y
more
más que un
healthcare
concepto
provision more
de
than
inclusión, ¿no es cierto?
in
Por lo
inclusion
tanto, hoy día ha
concept.
mutado un poco,
So
se ha actualizado todo
that has
esto con un
changed a little
enfoque
bit,
listo en
and
una
we have
estrategia
changed
comunitaria
that
de desarrollo
with
inclusivo,
a
porque
rights
hacia allá
approach and
queremos ir, ¿no?
inclusive development. That's
Que
what we
implique no
want to do.
solamente salud,
It should
sino que
imply not
también
only health,
educación,
but
inclusión
also
social,
education,
autonomía y
social
empoderamiento
inclusion,
de las personas con
autonomy, and
discapacidad.
empowerment for
Por
people
lo
with
tanto,
disabilities.
creo que esta
Therefore,
estrategia que en un principio, que en el fondo
this
era el
strategy
sentido de la RBC, ¿no es cierto?
that was the
Se ha
sense of the
transformado un poco con los tiempos y
RBC
creemos que
has
es necesario
transformed a long
volver, ¿no
time,
es cierto?, a un
and we
desarrollo
have
inclusivo con
to
enfoque de
go
derechos.
back to an inclusive
Pero es
approach with
una
a
experiencia
rights approach,
positiva.
a
Pero
positive
creo que
experience. Now,
fundamentalmente, y eso sin
fundamentally,
contexto ni tiempo, la
uh,
formación de profesionales y el compartir
training
protocolos que
professionals
permitan una
and
detección
sharing
precoz,
protocols
una
to
derivación
allow
oportuna y
um,
pertinente
early detection, early
mejoran, ¿no es cierto?, las
referral
intervenciones
that
tanto
is
básicas como
pertinent,
también la educación a
improves
usuarios, cuidadores
interventions at basic level, and also
coordinar
coordination
adecuadamente
between
los niveles de atención.
users and
Y la
caregivers
pandemia, me pasó a mí
at
en Semana
all
Santa, pero la
levels.
pandemia
And the pandemic
nos dio la importancia, ¿no es cierto?, de la teleatención. Y creo que
showed how
desarrollarla y
important
valorarla nos
it
permite
was to
comunicarnos con
have
nuestros
telecare.
colegas
We
y
can communicate
profesionales a
with our
distancia y
colleagues and
también asegurar
professionals
una distancia
remotely
acercando
and do
la rehabilitación a las
distant
personas y disminuyendo las barreras
health care,
físicas.
decreasing
Muchísimas gracias por
geographic
el tiempo, 2
barriers.
minutos
Thank you
15
very
segundos.
much. 2 minutes,
Doctora
15
Gallardo,
seconds.
adelante, 2 minutos tiene
Dr.
la exposición.
Gallardo, 2 minutes,
Adelante.
please.
Específicamente, tenemos diferentes
Specifically, we
estrategias.
have
Una,
different
hemos
strategies.
creado una
One
lista
is
corta
that
de
we
condiciones
created a
de salud
short
más
list of
prevalentes en El Salvador de
prevalent
baja
health conditions
complejidad,
in El
haciendo
Salvador that
uso
are
de la
low
clasificación internacional en
complexity. And we
funcionamiento de
have
la
used
discapacidad.
the
Y continuamos
classification of
capacitando a
disabilities,
profesionales
and we
de los
still
primeros
train
niveles de atención
professionals
en el uso de la
at
misma
primary health
en esta
care
ficha corta, de acuerdo a su
to
competencia y las
use
capacidades de
this
resolución que tiene el
fact
primer nivel de
sheet
atención.
according to
Esto
their
bajo un sistema de
competencies and
supervisión y
their
revisión
capacities.
especializada.
And we have
Otra
specialized
estrategia ha
revision and
sido la que
supervision for this.
mencionaba la
Another
doctora Marcela,
strategy,
que las tecnologías
as
de la
Marcela
información y las
mentioned, is
comunicaciones, como la
IT in
telerehabilitación, nos dejó
communication,
una muy buena
as
experiencia durante la pandemia
telerehabilitation,
COVID-19.
a great
Esto nos
experience
permitió
during the
aumentar
pandemic.
la
This
capacidad de
allowed us to
atención de nuestros
increase our
pacientes, la
care
accesibilidad,
capacity for our
disminuyendo esas barreras
patients and
geográficas y
better
facilitando continuar los
accessibility,
procesos de
decreasing
rehabilitación de nuestros
geographic
pacientes durante ese
barriers.
momento
So
y
our
esta es una
patients were
estrategia que también se
rehabilitated,
puede poner
and it's a
en
strategy
práctica
that can be
para
put to
trabajar en los primeros
practice to
niveles de
work
atención.
in the
El INSS
primary health
trabaja
care levels.
históricamente en la detección temprana de deficiencias
We
auditivas
work
a través de la
in early
realización de jornadas de
detention
evaluación
of
auditiva de
hearing
niños,
problems
jóvenes y
with
adultos,
assessment for
acercando nuestro
children,
personal
youth, and
especializado y
adults.
equipo
We
especializado a diferentes puntos
approach
del
the
país, los
people
cuales son
in different
realizados
points
a
in the
través de una
country. We do
coordinación
that through
interinstitucional,
interinstitutional
MINSAE, entre
coordination
otras instituciones, garantizando una
with
intervención de
several
rehabilitación oportuna
institutions,
a los
and
casos
we
específicos.
have timely
Y como última
intervention in
estrategia,
detected cases. The last
contamos con un equipo
strategy
técnico
is
capacitado
that
en
we
la
have
provisión de
a
tecnologías de
technical team
asistencia
that is
y en la
trained
guía de
in
provisión de
assistance
sillas de ruedas
technologies
en
and the
la OMS,
guidance of
quienes se
provision
movilizan a los
of
hogares de las
wheelchairs.
personas para
They
su
go to the
adaptación y
people's
ajuste de las
homes,
mismas y
so
obviamente eso mejora
they
su
are
bienestar, independencia
adapted,
y funcionalidad.
and that improves
Gracias.
their well-being
Bueno,
and
muchísimas gracias, doctora
functionality.
Gallardo.
Thank you
Bueno,
very
pues yo
much,
pregunto para
Dr.
el doctor Montero
Gallardo.
acerca de la
Same
estrategia
question
de
for
integración.
Dr. Montero about
Adelante, doctor
integration
Montero.
strategies. Dr. Montero. You have the floor.
Gustavo,
Thank you,
bueno,
Gustavo.
felicidades a todas las
Congratulations
panelistas por el
to all
trabajo
the
que hacen en sus
panelists for
respectivos
the
países.
work you do in your
Respetos a
respective
Consuelo por ese
countries.
trabajo en Haití, no debe
Consuelo,
ser
that
difícil el
work in
trabajo
Haiti must
en
be
un país que
very
nosotros
difficult.
sabemos que
So
es bien
I
complicado
respect
en
you
muchos
very
sentidos.
much.
De
It's a
modo que,
complicated country in
como decía
many
al principio,
ways.
todos nos enfrentamos a
All of
realidades
us
diferentes en
face
cada
different
uno de nuestros
realities
países.
in each one of our
En
countries,
Costa
as we know.
Rica,
In Costa
aparte de haber
Rica,
trabajado
besides having worked
proyectos comunes
in
con Chile,
common
con la
projects with
INR,
Chile, with the
también
INR in Chile, and
la
also
cooperación japonesa en
with the
proyectos
Japanese
comunitarios
cooperation and community
en la
projects
zona
in
indígena
the
del país, en el sur
indigenous
del
areas
país.
of the country, in
Se
the
han
south of the
utilizado todas
country. We have used
los componentes que
all
se
the
mencionan aquí en la
components
pregunta, que es la
mentioned
formación
here in the question.
interdisciplinaria, protocolos
Interdisciplinary training,
compartidos,
shared
telerehabilitación,
protocols,
supervisión especializada.
telerehabilitation,
Todos estos
specialized
componentes se han
supervision.
venido
All these
realizando a
components
través de
have
los
been
años.
used
Y
along the
desde hace
years.
muchísimos años hemos tenido
For many
procesos de
years, we
capacitación en
have
las
had
regiones,
training
en donde
processes
grupos
in the regions.
de equipos de
There,
rehabilitación se trasladan a las zonas rurales
rehabilitation
a
teams
capacitar
are
o capacitar
transported
incluso a
to
médicos
rural
generales
areas
de la región.
for
Pero
training the
lamentablemente
people in the different
todos
regions.
estos
Unfortunately,
procesos de
all
formación
these
interdisciplinaria, de guías clínicas
interdisciplinary
simplificadas que se han
training,
elaborado,
simplified clinical guides that have been
criterios de
prepared,
seguimiento, de
criteria for follow-up,
telerehabilitación, yo siento que
tele-rehabilitation,
realmente
etc.,
no se han consolidado, que
are
falta
not
realmente
really
consolidar estos
consolidated.
procesos,
We need to
fortalecerlos,
consolidate these processes,
promoverlos y que se
strengthen them,
conviertan
promote
realmente en
them,
una
so they
alternativa, en
really
un recurso, en
become
una
an
opción de los
alternative, a
servicios de
resource, an
rehabilitación
option
de
of
segundo y tercer
rehabilitation
nivel para
services
apoyar al
at
primer nivel
the
de atención.
second, so that the second and
Muchísimas
third level
gracias,
can
Dr.
support the
Consuelo. Creo yo opiniones muy,
first
muy interesantes
uh,
sobre estrategias
level
concretas.
of care.
Como veis,
Very
son
interesting
expertos en
opinions
esta región,
on
¿no? Nos
concrete
hablan de
strategies.
Costa
As
Rica,
you
de El
see,
Salvador, de
these are
Chile.
experts
Nos
in
dejan
our
experiencias que
region from
realmente
different
reflejan
countries
esta
with
importancia, ¿no?
experiences
Let
that
me
show how
reformulate the
important
question
this
in English
is.
for my colleagues Sarah and Melissa.
Voy
What strategies have been most effective for integrating the rehabilitation into the first level of care, whether within a team setting or institutional setting in resource-limited settings? Over to you, Sarah. Thank you.
Thank you, Gustavo. You know, the one thing I would say most important is just to remember that you don't always have to start from scratch. You don't have to, invent things from the beginning. Really look at what other institutions and facilities in your region are successfully implementing that have had positive community outcomes. And I'll give an example from the Bahamas when the Emory Collaborating Center was doing the STARS assessment in the Bahamas. We really saw that lack of accessible, affordable AT and durable medical equipment was widespread. And this is because it's not covered through the basic national insurance plan, but must be purchased out of pocket or sometimes covered by private insurance. And remember, because the Bahamas, being an archipelago of islands, all of that has to be imported. So you have import taxes that also go into the high cost. Um, After Hurricane Dorian in 2019, which was the worst natural disaster in the Bahamas history, it was widespread destruction. Well, after that, partially in response to all the rehab needs, the public hospital on Grand Bahama Island created this lending library of AT. And so what that was the rehabilitation professionals evaluate the patient for the appropriate device, and then patients can check something out like a library, use it as long as they need it, and then return it. And then, of course, it's inspected and cleaned and stored for the next person. So this allows for one, improved access, two, really community-centered care, and three, rehabilitation professionals and institutions can be at the front line of addressing not only clinical needs, but decreasing health disparities in their own communities.
Thank you very much, Sarah. Same question for you, Melissa. Over to you. Thank you.
Thank you, Gustavo, and thank you to my fellow panelists for their very insightful comments. I want to offer an example based on my own clinical practice, which is that I had the privilege of working as part of a multidisciplinary medical team to establish a rehabilitation service within the first level of care in a northern community in Canada. And our goal was to implement cross-training as well as a shared triage model and shared referral protocols to help get people to the right rehabilitation care at the right time and from the right provider. And I'm happy to report that it worked, but it worked because we started with the people whose health and whose function we aim to support. So one of our strategies was to consult with community members and medical teams at that first level of care to understand the rehabilitation needs that were specific to that community. And so we use this person-centered approach to then inform how we allocated our limited resources, selecting low-cost rehabilitation equipment that was appropriate for the needs of those people we were treating, rather than taking kind of a generalized approach. And most of those products are actually listed on the fact sheet we're discussing today. So from my perspective, one of the most effective strategies for integrating rehabilitation into the first level of care is understanding the rehabilitation needs of the people whose lives you aim to support and improve, as well as the contextual factors that shape how rehabilitation services can be or will be delivered in a given practice setting. Thank you.
Muchísimas gracias, Melissa. Como vemos, realmente no hay una sola estrategia, ¿no? Sino varias estrategias.
Thank you very much, Melissa. As we can see, there are several strategies, not only one, and they have a very high impact with creative and participatory interventions. Now we'll change the context of questions. We cannot have rehabilitation interventions without support. And we have our expert from the Pan American Health Organization who will talk about equipment and prioritization of this equipment. Yamil, what good practices do you know in terms of planning, acquisition, maintenance, and management of support technology at primary health care level? And what do we need, and what can the PAHO tool we have can help in this? Thank you, Gustavo. Concerning good practices in the region, what we have seen when we have collaborated and supported countries with is to develop lists of support products at national level. In some countries, we develop essential medical devices for the primary health care level. So countries have to develop and adapt from this list what they can to their national context, and that's for PHC. And this can be added to the list we have for PHC. Other tools we can use to plan are generating data on the needs for support products for the population. We have the rapid assessment of assistive technology, a tool that can be implemented in several ways to see what are the needs and the access barriers to support products. We have to evaluate that to see what is the real need that should be delivered and provided at PHC. The list that is in the list of equipment for rehabilitation, a list recommended for PHC with appropriate training for the personnel. We also recommend the use of different indicators when this list is being developed, like, for example, need, cost benefit, and other indicators such as the risk of providing these products at PHC. Concerning procurement, we have tools that help us to improve public procurement processes of support systems. We have technical specifications for them with a number of technical characteristics, quality, safety, and performance criteria to be fulfilled. We also have the PAHO strategic fund that helps governments in procurement processes to improve their supply chains and choose the products that better satisfy the population's need. They should also be appropriate and quality products that will really have a good return on investment. I'll include in the chat a few available tools and my email in case you need any technical support. We also have the procurement manual for support products. It suggests that besides this, you procure accessories and do the refurbishment for the appropriate use of these products. Also, for product management, we need to consider the creation of support product libraries that promote use, reuse, recycling, renewal, rehabilitation of support products so that when one user stops using that product, another person can use it and is adapted to the needs of the new user. We also recommend these products to be provided through appropriate services and professionals that are trained in these services. To do so, we have a virtual and hybrid course that provides the PHC personnel the knowledge they need and the tools they need, as well as the basic capabilities to provide simple, basic support products at PHC level. All this information is on the chat now, and I'll also pass you my email address. You can contact me. I'm at the Innovation and Access to Medications and Support Technology Department. If you're interested in receiving technical support on support technology or more information about this PAHO strategic fund for the public procurement of these products, you can write to me, and we can work on improving access to these technologies. Thank you very much, Yasmin, for your intervention. Clearly, we need to have support technology, and we get support from it to implement all this equipment and rehabilitation questions. Next question, something fundamental for this assistance: human resources, financing, and public policies. The question is, what are the main challenges on human resources when you provide rehabilitation services at PHC? What are solutions that have been tested? Broadening functions, training, distant support networks. We'll start responding this question with the participation of Dr. Guzman. Go ahead, Marcela. Well, human resources are complex. I think human resources are important in rehabilitation, and the difficulty is expressed also in other countries in the region. First of all, the number of professionals. Concerning professional scarcity, for example, rehabilitation physicians are scarce. We don't have any at PHC level, and not in number, but also in terms of distribution. We don't lack these professionals at country level, but they are centralized in urban areas and in the private system. This also means that the professional standard is not defined at country level. Lots of things depend on municipal governments and local governments. PHC is in the hands of local governments in Chile, and it depends on how much they are interested on these matters. They will provide more or less resources. There's lack of training of these professionals and a high turnover too. So what have we done transfer knowledge to local teams. That's the most important. We have courses and training that transfers technical knowledge to local teams that then define what the needs are and intervene at an early stage and low complexity ones, and then refer the more complex one, participate in protocols and clinical guides, and train professionals at the undergraduate level that values working in networks, empowering the autonomy of people, transferring knowledge to the patients themselves and their caregivers as well. Very integrating view. Dr. Montero, you have the floor.
Gustavo, yo no quisiera continuar con mi respuesta sin antes realmente agradecerte nuevamente por esta oportunidad en donde se está divulgando recursos disponibles que tendríamos en la región, en muchos lugares que tiene OPS, que tiene la OMS y que muchas veces son desconocidos o no llegan a donde tienen que llegar, pero son documentos útiles que nos pueden ayudar tremendamente en nuestro trabajo. Yo pienso que de nuevo los componentes que están anotados en la pregunta, escasez de profesionales, una distribución desigual de los profesionales y una alta rotación de personal, son factores muy importantes a la hora de enfrentar los retos que tenemos en la región para proporcionar servicios de rehabilitación en un primer nivel de atención. Aunque la escasez de personal se menciona siempre como un factor clave, yo no creo que sea una razón tan fuerte y tan poderosa y que tenga la importancia que le damos a veces para que se puedan limitar los procesos y los recursos a ese nivel. Quizá lo que haga falta sea la necesidad de motivar en gran medida al personal de primer nivel de atención, de llevar
provide
ese mensaje de sensibilización
this
sobre la importancia de
awareness
proporcionar atención, mejorar la funcionalidad, mejorar
to
la
improve
participación
functionalities
de
and
los
improve the
integrantes de las comunidades
functionalities of
nuestro
the
país. Esto
community's members in these
ayudaría a
processes, because this
proporcionar
would
esta
definitely facilitate
sensibilización en general
rehabilitation
a
professionals and
veces
teams
quizá
to find a
equipo de salud
sensitized community and a
sensibilizado
sensitized
en
health
el primer nivel de
team
atención.
at the first level of
Quisiera
care.
tampoco dejar
And
de
I
mencionar
also
un comentario
want
que
to
mencionaron en el chat relacionado con
mentioned
la
a
importancia
comment
de
in the
salud
chat
mental
about the
en todos
importance
estos
of
procesos. Nosotros
mental health in
sabemos
all these
las
processes.
condiciones
We are all aware
físicas
of
que
the
tenemos, sabemos las condiciones
conditions, but
en la
not
salud,
always so,
especialmente
of the
en
conditions,
servicios de primer nivel de
living
atención,
conditions of the people
pobreza, de falta
in
de
the
recursos,
first level of care, poverty,
depresión,
like
esas
research
mismas
says,
condiciones, de modo que
depression
podemos
for
ayudar
these same conditions, so that a mental health
incorporar
is an
necesario
important
dentro de
and
todo este
necessary
proceso.
component in this process.
Totalmente de acuerdo contigo. De hecho,
Totally
forma
agreed
parte
with
también
you.
del
It
material
is
que tenemos
also
previsto también en
part of the
la hoja de vida.
materials
Bueno, pues
that
última
are
pregunta para
mentioned
Gallardo.
in the
¿Qué nos puede
equipment
resolver los
list.
principales retos en el
Same
desarrollo
question
de
for
rehabilitación
Dr.
equipment?
Gallardo.
Súper interesante.
Uh,
Adelante.
Thank you. Yes. Thank you, Gustavo. I would like to start by mentioning that we have an empowered, strong, robust health policy for rehabilitation, and we are coordinating and working on training personnel at the first level of care, and with a short list so that the first level of care can identify and act and have the resolution capacities according to their responsibilities, so that health personnel is, as we all know, kind of a disaggregated. This is a commitment in El Salvador to have an integrated health service that's a national digital platform to modernize and digitize the continuity in care services with a focus on rehabilitation where primary healthcare has resolution capacities and a follow-up for low complexity conditions that can be eventually referred to higher levels of resolution. Also, there is a telemedicine, educational telemedicine initiative that focuses on the first level of care in El Salvador to develop to present topics of interest and where we have rehabilitators also, including prevention, health promotion, early detection, or rehabilitation, more specialized rehabilitation services, and through permanent interconnection, connectivity. Yes, great. How we can use new technologies for initial care at the first level. Consuelo, over to you. Yes, I totally agree with the other panels. I think that the main challenges for integration of rehabilitation is include those three. In the first place, the lists and the training of occupational therapists that's relatively recent in Haiti as well as in other regional countries. The number of available staff is still insufficient to address the people's needs. And as a response, we have supported the training initiatives of new professionals at universities as well as rehabilitation technical experts because expanding the labor force is critical to strengthen services at the in the longer term. And as Marcela said, we have to address the unequal distribution of our professionals. And I think this is a reality in many of our regional countries. Most of the specialized services are concentrated in the cities where rural communities have very limited resources. And to address these gaps, we have the clinical and mobile clinics and community-based strategies to bring professionals to those areas where there are no permanent medical staff. And also, the services will hardly be able to address all the needs. So we are working at identifying a first level of care services to provide initial triage and eventual reference of these persons who need rehabilitation services and also households of supervisions under professional supervision. And I think it is important that we have to strengthen interdisciplinary teams where each profession provides and has a shared understanding of the objectives of rehabilitation as well as people's participation. I think this is indeed a key challenge that requires an intersectoral approach, and that when we finally understand that people's participation is critical in providing rehabilitation, I think we're doing very well. In time to the last question for our panelists. And since many of the attendees are members of the health ministries and directors, if you had to make a key recommendation for the countries in the Americas for the next 5 years in the integration of rehabilitation, the first level of care, what would be the first recommendations? We have a couple of minutes for your responses. Let's start with Consuelo once again. Yes, I think that integrating rehabilitation at the first level of care is an essential component of universal health coverage and not as an optional service or highly specialized services. We often think that rehabilitation requires large centers and high technology or researches that are difficult to provide, but our experiences shows that it's important to create a significant impact with relatively simple technologies, with trained teams and appropriate technologies in many contexts, in particular in uh, rural areas where simple things like a wheelchair or a walking cane can make all the difference between independence and autonomy and between isolation and participation. So it is not enough to expand infrastructure, but we have to train personnel and expand our services and strengthen the capacities of a primary care services to serve the people's needs. I think that we have a great opportunity as a region because these rehabilitation services are increasingly needed as a consequence of the population's aging, the demographic transition, and natural disasters. But we cannot wait. We have to move towards health systems where access to rehabilitation becomes reality for all, regardless of their economic conditions. And I would like to underscore that rehabilitation should not be seen as a sanitary intervention. Is an investment in autonomy, participation, and opportunities. When a person recovers the opportunity of working, participating in the communities, and taking care of their families, their quality of living improves, and the economic and social prosperity of the community also improves. Thank you very much, Consuelo. Now, over to Marcela. Thank you. I think that if I had to make any kind of a recommendation, that if we expect to have a real and sustainable impact in regards of rehabilitation, we have to integrate it into solidarity health networks, because otherwise we have fragmented services and inefficient resource utilization. And this should be at the basis of rehabilitation, because this requires that basic interventions at a low cost has a great impact on social costs and health outcomes. It improves the functional recovery, the return to the work life. There is less dependency. There is less expense in complications, health complications, and assures the continuity in addition to care, and provides socioeconomic and demographic equality. It assures the universal rehabilitation coverage as a right and not as a favor, or something that should involve very high costs. I think it is important to institutionalize and structure this approach. Thank you very much for your words. Now, Dr. Gallardo. Yes, as has been mentioned, like for every 5 years, it'll be advisable that PAHO member countries put into practice the interventions package to have a national intervention rehabilitation plan that's well established, that includes all these items that we have mentioned: governance, financing, access to rehabilitation services, in supported technologies and other. I think that having this document for each country would be very advisable. We are currently reviewing actually the corresponding document, and the weak care at the first level of care in regards of rehabilitation is something that everybody is aware of, and this is something that is at the proposal of our document as a strategy, and we're working simultaneously in providing this support. And along that line of thinking, we have these professional training programs that including doctors, nurses, first level rehabilitation care. In our own countries, we have only one physiotherapist in some remote health units. So we have to work basically on prevention, and as has been recommended, and also the use of information technologies is also very important. This is recommended for countries because it increases access and allows us to better reach our users and patients. We decentralize the specialized care that is so limited, and it improves adherence to treatment of our patients and their awareness that they have to commit to their treatment, among other benefits of rehabilitation. Thank you. Thank you, Dr. Gallardo. Now over to Dr. Montero. What is a key recommendation that you would make to government officials in regards of integrating rehabilitation in first care services? I think that thank you very much, Gustavo, and I think that we have to understand the differences and divergences between the national countries and the existing social gaps, and knowing that in some countries the private sector plays a very important role in providing these services, and that are not always available and cannot be afforded by poor people that are most of the people with disabilities. Unfortunately, poverty is intimately related to the component of disabilities and the situation that remains during people's lives in most Latin American and Canadian American countries. We, if I'm right, have the laws. We have ratified the Convention on the Rights of the Peoples with Disabilities, but we do not. And we have the guidelines and the technical resources that have been prepared by international organizations that are available, but I think that we are not using these available resources properly. And as has been already mentioned by Marcela, this important also to build networks in our own countries for rehabilitation services, that we all share our experiences. So a recommendation that I would like to make to ministries and national health systems stewards is to contribute to this dialogue and to help to have these laws actually enforced for health officials to enforce them and to comply with, which they don't. We are aware that PAHO cannot intervene in those issues, but in our own countries, we can put pressure on authorities for these laws to be complied with and enforced. In Costa Rica, we have over 1,000 basic teams that address more or less complex situations. The resources are available, at least in my country, that would facilitate making rehabilitation services available at the first level of care. And finally, I think that with all these things that we have mentioned here, it is obvious that we can share country experiences. We must not waste what is the good things that are done in some countries, and let us all take advantage of that. I think that is an important advice to our ministries. Thank you very much for those recommendations. I am thrilled by the participation. We have had over 500 people that were connected at some time or another from all these countries across the Americas, from Aruba to Venezuela. I think this has been a extremely good participation. Unfortunately, we have run out of time, but given the number of pending questions, we could easily have another webinar. The documents and will be available, of course, and we will be assessing the importance, the impact of this webinar, and the need to address the integration of rehabilitation services at the first level of care. This document that has been prepared by the experts that have joined in this panel will be useful to the services in your countries, and that, as Dr. Matera said, we can foster the integration of rehabilitation into the first level of care that is a need in the lower and medium countries, but also in the medium and higher income countries. Thanks again to our panelists and the collaboration centers and all the participants that have joined in this webinar. This document is available in webpage. The recording of this webinar will be available on the PAHO webpage in the rehabilitation section in coming days. So once again, thanks again, and see you soon.
Gracias a todos y todas.
Un gusto. Muchas
Bueno,
gracias.
muchas gracias a todos.
Thanks to everybody.
Muchas gracias a todos y a todas. Que tengan buen día. Chao.
Have a great day.